Sharon, thanks so much for being nice enough to be with me today. I'm going to introduce you a little bit. Dr. Inouye is a professor of medicine at Harvard Medical School. She became very prominent over 30 years ago in the early 1990s, becoming a prominent expert in the field of delirium. And she's going to talk about delirium today. It's not the same thing as Alzheimer's disease or dementia. 10 years ago, I first met Dr. Inouye. At our own hospital, we'd already been doing a lot of stuff Dr. Inouye was central to. And that's because across the country and around the world, it was becoming very clear that it was important to prevent delirium, to recognize it and to treat it. And when I first met her, I was in awe of Dr. Inouye because not only is Dr. Inouye's work in the area of delirium, but she's done a lot of work in the area of leadership and also in how to create big change in the way healthcare is done. But then, actually, as I got to know her, I just really was struck me how nice of a person and absolutely kind Dr. Inouye is. So she was kind enough to say, "Hey, yeah, sure, I'll talk a little bit about delirium." Dr. Inouye, on that note, what is delirium?
Thank you, Dr. Wong, and I'm so pleased to be here. And thank you for the kind introduction. So delirium is, as Dr. Wong said, different from dementia. It's an acute change, an acute confusion that typically arises in the face of either acute illness, like a pneumonia or an infection, a medication change, or surgery. And the reason we want you to know about it is very common in older adults. It's common in the hospital, in the emergency room, in the surgical setting, and in intensive care unit settings. And it became really common during the COVID-19 pandemic. And so we both felt it was really important to bring this to attention of family members and caregivers so that you know something about it. It doesn't always, mean someone is severely ill, but it can mean that. And so that's why we think it's important for families to know what it is and how to recognize it.
So actually, this is an interesting point you make about recognizing it, Dr. Inouye, because, I had that interview with Dr. Leff, and he was visiting his dad in the hospital, and he recognized that his dad was delirious right away. And sure enough, the medical staff, the hospital staff didn't recognize it. So what would you tell caregivers about how would a caregiver recognize delirium?
Yes, absolutely. And I have to highlight that what you just said, Dr. Wong, that it's not unusual for hospital staff, including nurses and physicians, to not realize the delirium is happening. And I can explain more about why in just a moment. But I do want to emphasize that family members are often the ones who provide the earliest recognition of a delirium. And you family members, you may ask why, because you recognize something's not right about your loved one, right? You know something's not right. And it's that whenever I have a family that comes to me and says, my loved one is not right, I can't quite put my finger on it, but they're not right, something's wrong, then as a physician, as a geriatrician, my antennae go up, way up. And typically what I'm doing is rushing in the room to examine the patient. But what do you mean about not being right? So some of the things as a family member that you can look for are they're not eating well, they're not paying attention, they're not able to do the usual things that they do. So for instance, if they read the newspaper in the morning and they're not at all interested in that, They don't even want to watch TV. They don't want to read their books or do any of their usual activities. Maybe they don't even get themselves dressed as they usually do. You know, we're talking about a change in their usual behavior. So you may not even notice confusion or disorientation yet. These are even early signs that occur before that. But how should it be recognized? What are the diagnostic criteria? So in the textbooks right now, what the diagnostic criteria are number one is an acute change from baseline. And that just means the person is changed from how they usually are, right? And so that's where families have the advantage, right, over healthcare professionals, because they have the opportunity to observe their loved one over the course of time, and they know there's been a change. The second key feature is called inattention. And what does that mean? That means impaired ability to pay attention, to focus on what's going on around you. And how does that manifest itself? So someone's not able to focus, they're not able to pay attention to what you're saying to them. So if you're a family member and you're asking your loved one to do something and they don't do it, and you repeat the instruction and they still don't do it, well, it might not be that they're ignoring you. It might really be that they can't do it, that they can't pay attention, they can't register what you're saying. And then how that inattention can also be manifest is they can't follow what's going on around them, so they seem very confused. That can manifest as the disorientation. The other two key features of delirium are that someone can't stay awake. They are dozing off frequently, or they're sleeping all day. So if you see that occur and that's unusual for your loved one, that's another warning sign. Alternatively, they can be up all night. And if that's abnormal, and sometimes that can be associated with agitation, then that's another warning sign. The final warning sign is disorganization of thought. And that is the true confusional state where they may be talking nonsense. They could be saying nonsense words. You can't follow what they're trying to say. What they're saying doesn't make sense. And so that's where you get to disorganization of thought. So those are the key features of a delirium. Delirium also tends to get better and worse throughout the course of the day. And that's one of the things that can throw doctors and nurses off, because sometimes people with delirium can seem 100% normal. And then 10 minutes later, they can be completely inattentive and disorganized, those symptoms I told you earlier, or they can be completely out of it. And then 10 minutes later, they're completely okay. And so that kind of waxing and waning can also make it very difficult to pick up a delirium. And because the change is so essential to the diagnosis, it's not unusual that a healthcare professional who just sees someone for the first time in the hospital, and they may be disoriented, and the healthcare professional may think, oh, they just have a mild dementia. But without knowing that that's a substantial change for that person, they may overlook it. So that's why a family member is so critical to help recognize a delirium. And that's why I want to empower families to trust their instincts. If their loved one is not right, to bring that to the attention of a medical professional, particularly if that's a change. You have to trust your instincts and just keep saying that. Just keep saying, something is not right. Something is not right with my loved one. I need an evaluation. And, now that you're educated about delirium, you could say, could this be a delirium? Is it possible? And so I want to empower family members to do that.
Just to really emphasize what Dr. Inouye is talking about, it's not uncommon for physicians to see something first thing in the morning, and the nurse is saying, oh God, it was a terrible night, blah, blah, blah. And the physician, sees the patient either asleep or saying, hi, doctor, and talking pretty normally. And the doctor says, patient looks fine to me. And that happens so often. Then we say, don't, time out. You're actually probably, please be more about knowing what delirium really is. And then that other thing is of course, everybody gets a mental status examination, and they'll say, spell world backwards, and they may get it right, but it will be like D, and then they'll score normally, but it takes forever to get the right answer out of them because their attention is so poor. And then the scoring may still seem normal, but what you really need to know is that they're not paying attention. So
exactly. So those are just wonderful points, Dr. Wong, and ones that I want to highlight as well. And that's why recognizing delirium can be difficult. Exactly. And even on those cognitive tests, I try to teach all my students that it's not so much the score, it's how they answer the questions, right? Are they crisp and sharp, or is there long pauses and delays, and it just as you described? And that's what you want to know. And then that change you said about, having a really difficult night and the nurse is saying, oh my goodness, they were confused all night long. And then the doctor comes in for 5 minutes in the morning on rounds and the patient, looks normal during that time. That happens so often because even we know that delirium, the worst time for delirium is between 10 o'clock at night and 6 in the morning. And so when the doctors come by at 6:30 or 7 and the patient looks totally normal, that's so classic, right? It's so classic. And so again, it takes, either nursing or the family member really advocating and saying, no. Something was really off last night. We have to evaluate. We have to do something. So thank you.